Shall we start? It's 9:05. So today Sachin is going to present on an important topic, approach to inborn errors of metabolism in newborn. I think like many times we face IEM. I request Sachin to highlight the approach of IEM in neonates. Over to Sachin.
Thank you, ma'am. Today I'll be discussing about approach to inborn errors of metabolism. Hello, ma'am.
Sachin, we can hear you. Please continue.
Yes, ma'am.
We can see your screen.
Yes, ma'am.
And
yes,
we can hear you.
Yes, ma'am. Thank you, ma'am.
Maybe you should keep a little bit closer.
Okay, ma'am. Okay, ma'am. Good evening, everyone.
Now it is clear.
Okay, ma'am. Good evening, everyone. Today I'll be discussing about approach to inborn errors of metabolism. So I'll be discussing the topic under these headings: introduction, approach to IEM, a classification of IEM, algorithmic evaluation of hyperammonemia, metabolic acidosis, and hypoglycemia, investigations and management of IEM. So what is metabolism? So it is a process of breakdown of complex molecules into simpler molecules by the action of enzyme A along with the cofactor. So if at all, if there is any defect in this pathway, it can lead to inborn errors of metabolism. So the term IEM was coined by physician Gerard, and if you take incidence, these disorders are individually rare, but collectively they can be common. And especially in newborn period, they pose a diagnostic challenge because they can present with non-specific signs and symptoms. So hence, we should be having high index of suspicion to diagnose these conditions. So before going to topic proper, there are some misconceptions about IEM. So I would like to discuss about them. The first is IEM need not be considered in those with negative family history. So as we all know, most IEM are being inherited as autosomal recessive disorders, but there are some exceptions where they can present sporadically. So even though there is no family history, in certain situations, we should be considering possibility of IEM. So second one is physicians need to remember complex pathways and management. Need not be always, because if we follow a algorithmic approach, then it is always simple and easy to diagnose these disorders and manage. So third one is, it may be true that sepsis is more common than IEM. So if you are managing a baby with the features of sepsis, but culture comes negative and the baby doesn't have any risk factors of sepsis, then we should be evaluating that baby for IEM. So the fourth one is, a normal newborn screening report excludes IEM. So we all know that the newborn screening, whatever we do, does not include all the IEM. So there are IEMs like mucopolysaccharidosis, which are not included in our newborn screening. So even though the newborn screening is normal, there still lies a possibility of IEM. So the final one is, breastfeeding is contraindicated in majority of IEM. So if at all a baby present with metabolic crisis, we'll be keeping the baby NPO for 24 to 48 hours. So when after the stabilization of the baby, we can start the baby with quantified amount of milk. So 1 in 2 conditions like galactosemia and very long chain acyl-CoA dehydrogenase deficiency, their breast milk is totally contraindicated. So when and how to suspect IEM? So if at all, if there is any history of fetal wastages, eye drops, or severe IUGR or neonatal deaths or sudden infant death syndrome, then we should be suspecting IEM. So some of the IEMs like MPS 4 and 7, they can present with features of eye drops antenatally. So some of the IEMs like congenital disorders of glycosylation and Zellweger syndrome, they can present with dysmorphism at birth. So some of the babies like they can present with unexplained clinical deterioration following a period of normalcy. Usually this type of presentation is seen in group 1, that is intoxication disorders, which I will be dealing in further slides. So other presentations like unexplained odor, unexplained shock, or abnormal visceromegaly can be presentation of IEM. So some of the IEMs like galactosemia and multiple carboxylase deficiency, they can mimic sepsis. So in any baby who presents with abnormal acute laboratory abnormalities like refractory hypoglycemia or persistent hypoglycemia, refractory metabolic acidosis, or hyperammonemia, we should be keeping the diagnosis of IEM in differential diagnosis. So coming to approach, history plays a major role in diagnosis of these disorders. We should be knowing any undiagnosed neonatal deaths or childhood illnesses which are running in the family, and putting a 3-generation pedigree chart is a must in evaluating such cases, because we'll be knowing the consanguinity of the parents, and if at all, if there are any family members who are running with undiagnosed clinical conditions. So we should be asking proper family history in evaluating such cases. Coming to age of onset, the IEMs can present with varied signs and symptoms from neonatal period to adulthood. This is mainly because the signs and symptoms mainly depends on the developmental stage of a particular organ system. For example, cholesterol biosynthetic defects, paroxysmal biogenic disorders, and lysosomal disorders, they can present at birth. So coming to IEMs affecting mother and fetus. So if at all IEM is present in either of the mother or fetus, it can affect the health status of the other. So, for example, if mother is suffering from phenylketonuria, if she is not under treatment, then the phenylalanine level, which is in high concentration in the mother, it can get actively transported to the fetus, as the phenylalanine is a metabolic teratogen, can cause dysmorphism in the baby. And they can also have physical and mental retardation along with the severe congenital heart diseases. So if the fetus is having IEM such as a long-chain hydroxyacyl-CoA dehydrogenase deficiency, the metabolites which are formed in the fetus, they can get actively transported to the mother, and the mother can present with features of L syndrome or acute fatty liver of pregnancy. So coming to provocative events, so some of the catabolic circumstances like infection, stress, or fever, they can unmask these inborn errors of metabolism. So weaning is another important history that we should be asking, where if you take the group 2 disorders that are energy deficient disorders, they can be normal till 6 months of age. So for example, hereditary fructose intolerance, if you take these babies will be normal from birth to 6 months of age. As and when the weaning is started, as they're exposed to fruits or sugar containing substances, they can present with recurrent vomiting. So coming to clinical presentation, so some of the IEMs, they can present with antenatal features like MPS 7, CTG, they can present with features of eye drops. Whereas LCHAT deficiency, they can present as features of ELP syndrome or acute fatty liver of pregnancy in the mother. So eye cell disease usually presents with cerebellar hypoplasia as a USG finding antenatally. So coming to IEM which present with predominantly encephalopathy. So, for example, urea cycle disorders, MSUD, organic acidemias, and FAODs, they can present with features of encephalopathy. Usually, if you take a urea cycle disorder, they'll be having hyperammonemia, which is a respiratory stimulant. Again, it can cause cerebral edema in the baby. They may present with hypotonia with encephalopathy. So if you take maple syrup urine disease, usually they may present with slow abnormal movements involving boxing and paddling movements of the extremities. And if you take organic acidemias, usually they'll be presenting with fast abnormal movements with dehydration. So coming to neurological deterioration, predominantly presenting as seizures. So some of the IEMs such as paradoxin responsive seizures, pyridoxamine phosphate oxidase deficiency, cerebral folate deficiency, sulfate oxidase deficiency, molybdenum cofactor deficiency, or NKH, they can present with refractory seizures, and even EEG can show burst suppression pattern in these disorders. So again, in pyridoxine responsive seizures, they can present antenatally, where mother will complain of increased fetal movements, where it is because of in utero seizures. So again, the molybdenum cofactor deficiency, it can mimic features of HIE. So we should be keeping a DD of molybdenum cofactor deficiency, where baby present with features of HIE, but there was no any perinatal event causing HIE. So again, if you take non-ketotic hyperglycemia, usually these babies will be presenting with truncal hypotonia, myoclonic jerks, and even hiccups. So some of the disorders which can present with hypoglycemia are fatty acid oxidation disorders, glycogen disorders, and fructose 1,6 bisphosphatase deficiency. And some of the IEM, they can present with liver cell failures or cholestasis, such as bile acid synthetic defects, mitochondrial DNA depletion syndromes, and tyrosine and galactosemia, especially, they can present with acute liver cell failure in the neonatal period. So fatty acid oxidation disorders and respiratory chain disorders, even they can present with the cardiomyopathy or arrhythmia. And some of the IEM, they can present with the dysmorphism, such as connected disorders of glycosylation, where they can present with dysmorphism, dysmorphic features like dolichocephaly, low set tears, and bossing forehead, and they can have inverted nipples and abnormal fat distribution that is evident here, and amatose is also a feature of CDG. So another example for IEM which will present with dysmorphism is Zellweger syndrome, where they can have flat faces, depressed nasal bridge, high forehead, and large fontanelle, micrognathia, and eye arch palate, and redundant neck fold, which is evident here. So into classification of IEMs. So if you take proteins, carbohydrates, and lipids, the metabolic disorders pertaining to proteins are amino acidopathies, organic acidemias, and urea cycle defects. If you take the carbohydrates, then gluconeogenesis and glycogenolysis are the disorders which are pertaining to carbohydrate metabolic disorder. And FOADs and cholesterol synthetic defects come under lipid metabolic disorder. So usually the protein metabolic disorders, usually they present with intoxication, and carbohydrate and lipid metabolic disorders, they'll be presenting with energy deficiency. So depending upon the clinical presentation, we have other classification, that is energy deficiency and intoxication and storage disorder. To understand this, we need to know the pathophysiology. So if at all, if there is any substrate that is undergoing metabolized in the body, it should be it will be acted upon by an enzyme along with cofactor. So if at all, if there is any deficiency of enzyme or cofactor, the substrate will get accumulated. So after the accumulation of substrate, it may get acted by another enzyme, that is enzyme B, and it may get converted to metabolite that may be toxic to the body. So the accumulation of substrate or metabolite can cause a toxic to the organs of the body. So if there is no production of product, they can present with energy deficiency. So usually the protein disorders, usually they will present with intoxication, and carbohydrate and lipid disorders, they'll be presenting with energy deficiency. The third group, that is present is the cell organelle disorder, that is storage form. They can be presenting with storage disorders. So usually this classification mainly helps in understanding the pathophysiological perspective, and there is another classification given by Society for the Study of IEM, where it classifies IEM into 15 groups based on the biochemical pathways. So coming to group 1 disorders, that is intoxication group, the main pathophysiology here is mainly because of accumulation of toxic metabolites, and usually they will be presenting in the neonatal period, and they'll be having a period of normalcy, and the usual presentation here is the encephalopathy. And the embryo-fetal environment is not affected in group 1 disorders, and the diagnosis is mainly straightforward. Usually these disorders are treatable. Coming to case scenario 1, it was a term EGA girl delivered by normal vaginal delivery to a 23-year-old G3P2L1 D1 mother who had a normal transition at birth. Baby was feeding well and passed urine and meconium and discharged on day 4 of life. On day 6, mother noticed baby having a decreased activity and abnormal cry, for which she had taken the baby to the local hospital where hypoglycemia was noted. On asking the history, they found that the first sibling who was there also had delayed milestones, hypopigmented ear, and frequent focal seizures were also there. So this first sibling was evaluated with TMS and during GCMS, showing leucine, valine, and isoleucine. An MRI of this baby showed bilateral putamen hyperintensities. So the diagnosis of maple syrup urine disease was made in that sibling. So after that, this child expired at 1 year, 10 months of age, and the parents were evaluated for carrier status, and they found to be heterozygous carriers for the same. And with this history, the local pediatrician sent a TMS of the present baby, which showed elevation of leucine, isoleucine, and valine. And urine GCMS was showing elevation of excretion of 2-hydroxy-3-methyl valeric acid, 2-hydroxy-isovaleric acid, and 3-hydroxy-butyric acid. So with this background, baby was referred to us on day 8 of life with weight loss of 8.6%. On receiving, baby was irritable with these features. We can see the encephalopathy baby with abnormal cry and boxing and paddling movements of the limbs. After receiving, we started the baby on IV fluid, and the quantified amount of mother's own milk was started. We sent Galac, which was found to be normal, and we started the baby on levocarnitine and thiamine supplementation, along with the amino acid metabolic disorder 1 formula. And we found that there was worsening encephalopathy, and for which baby underwent peritoneal dialysis. So before dialysis, we had sent pre-PD metabolites, that is alloleucine, leucine, isoleucine, and valine. So they were elevated, and the post-PT metabolites which were sent showed decrease in all these metabolites. So the MRI with MRS which was done showed involvement of bilateral basal ganglia and cerebellum, with the MRS showing peak at branched chain amino acids and keto acids. So a diagnostic bara was done, which was reported to be normal, and we continued the baby on carnitine and thiamine supplementation, and the AMD1 formula later changed to MSUD formula, along with quantified mother's own milk of 150 ml per day, and the baby is under developmental follow-up. Coming to group 2 disorders, these are energy failure disorders. Usually the pathophysiology behind this is because of energy failure, production or utilization. So usually they'll have a variable presentation, because some of the IEMs such as fatty acid oxidation disorders, they can present in the newborn period, whereas hereditary fructose intolerance, they can present in the infantile period. So here the period of normalcy may not be present. Usually they'll be presenting with hypoglycemia with multi-system involvement. So this is mainly because they are the energy dependent organs such as liver, brain, kidney are mainly energy dependent. So they can have multi-system involvement. And these group 2 disorders are further classified into mitochondrial disorders and cytoplasmic disorders. So broadly, the mitochondrial disorders are non-treatable, they are progressive, and cytoplasmic disorders are partly treatable and they are less severe. For example, for cytoplasmic disorders like gluconeogenesis or glycogenesis, they can present. And usually the diagnosis of these disorders are difficult, and they might need functional studies. Coming to case scenario 2, it was a term, a boy baby brought from postnatal ward with no audible heart sounds or breathing. There was history of feeding 10 minutes ago, and this baby was born to non-consanguineous married couple who had a history of IUD at 24 weeks of gestation. And baby was intubated with coordinated chest compressions were started, and needed adrenaline boluses, and CPG, which was showing low, received dextrose bolus for the same. And the ECG was connected, showed ventricular fibrillation, for which baby received shock. In spite of best resuscitative measures, baby could not be revived and later declared dead. But we were able to manage, get the samples from this baby, and we had sent for TMS and DNA storage. The ABG, which was showing metabolic acidosis with lactate being high. So, and the GALAC workup, which was done. The GALAC is nothing but glucose, ammonia, lactate, ABG, and ketone, was showing hypoglycemia, and ammonia was elevated. There was high lactate. There was evidence of metabolic acidosis, and ketones were negative. The report sent for TMS showed significant elevation of C16, C18, and C16, which was suggestive of CPT2 deficiency or CACT2 deficiency. CPT, that is carnitine palmitoyl transferase 2 deficiency. CACT is carnitine acyl carnitine translocase deficiency. Usually these two enzymes are seen mainly in transport of acyl carnitine from cytosol to mitochondria. So if there is, this is the translocase transporter here. This is the CPT1 enzyme. This is the CPT2 enzyme. So if at all there is any deficiency of these enzymes, they can present with in the newborn period. So the diagnosis of fatty acid oxidation defect was made in this baby. So coming to group 3 disorders, that is storage disorder, the main pathophysiology here is usually the cell organelles like endoplasmic reticulum, Golgi apparatus, or peroxisomes are affected, leading to storage of macromolecules in the cell. So usually these disorders are presenting in the later stage of life. But there are exceptions like peroxisomal biosynthetic defect, like Zellweger syndrome. They can present in the newborn period with neurological manifestations. So these disorders usually they'll have multi-system involvement, presenting with hepatosplenomegaly, bone and brain involvement. And the embryo-fetal period is also affected here. Even some of the disorders like MPS 4 and 7, they can present with features of eye drops antenatally. And diagnosis here mainly depends upon enzyme assay, and most of the lysosomal storage disorders like MPS 2, 4, 7, they have enzyme replacement therapy. Even bone marrow transplantation can be offered for these group 3 disorders. Coming to case scenario 3, it was a term EGA girl delivered by normal vaginal delivery to a 22-year-old primary mother, and it was a 3rd-degree consanguineous married couple. So antenatally, the baby had severe ventriculomegaly with 18 mm, and there were droplet changes, and the mother was CMV IgG positive with high avidity. Prenatal transition-wise, baby cried at birth with Apgar of 5/10 and 7/10, and in view of RDS score of 4/10, baby was connected to early CPAP. On examination, baby found to be dysmorphic with features of flat faces, depressed nasal bridge, high forehead, large fontanelle, and there was micrognathia and eye arch palate with low set ears with redundant skin fold of neck. And there was severe generalized hypotonia, and there were no spontaneous activity. Red reflex was present, and neonatal reflexes, sucking reflex, Morris reflex were all absent, and DTR was also absent. the workup which was done, the echo showed EST of 3 mm and PD of 3 mm, USG, LFT, RFT, and complete hemogram were reported to be normal. And X-ray of knee joint was showing patellar stippling. The ESG cranium which was done showed bilateral germinolitisis with dilated lateral ventricles. With these features of biochemical clinical picture, we suspected Zellweger syndrome, and we had sent plasma very long chain fatty acid assay, which was showing the pristanic acid level was high and other long chain fatty acid levels were high. This is mainly because why we sent a very long chain fatty acid assay, because peroxisomes are the center for metabolism of these very long chain fatty acids. If at all the peroxisomes are absent, obviously the very long chain fatty acids will be elevated. And we also sent plasmalogen levels in this baby, because plasmalogens are glycerophospholipids which are synthesized in peroxisomes. If the peroxisomes are absent, then we were expecting plasmalogens to be low. So the report was reported to be the plasmalogens levels were reported to be low, and we made a diagnosis of Zellweger syndrome in this baby. Coming to algorithmic approach, mainly algorithmic approach will help us in narrowing down the diagnosis of IEM. And usually whenever we are evaluating a baby with IEM, we should be starting with the screening tests like Gallup workup, TMS, urine GCMS, and then the next step will be specified test for the disorder, and the last thing will be molecular diagnosis. Mainly the molecular diagnosis helps us for genetic counseling and planning for future pregnancy. So coming to Gallup workup, Gallup is nothing but glucose, ABG, lactate, ammonia, and ketones. So this Gallup workup mainly helps us to differentiate the common disorders such as organic acidemias, urea cycle defect, and fatty acid oxidation defect. So if we take organic acidemia in Gallup workup, they can show evidence of hypoglycemia, acidosis, and lactate being high, ammonia and ketones can be high. This is mainly because if you take organic acidemias, these are volatile acids. So whenever acid is accumulating in the body, the acidosis will be evident. So they'll be having acidosis. So as we know, the organic acidemias are mainly because of a protein metabolism defect in the protein metabolism. So proteins are the sources of ammonia. So ammonia elevation is also evident here. So the IEM which is presenting with hyperammonemia with acidosis, we should be suspecting organic acidemias. So if you take urea cycle disorders, as we know, urea cycle is the main pathway for detoxifying ammonia. So if at all there is a defect here, ammonia will be elevated. So ammonia, as ammonia is a respiratory stimulant, they can have respiratory alkalosis. So there will be no acidosis in urea cycle disorder. So the hyperammonemia with respiratory alkalosis, the diagnosis should be urea cycle disorder. And the next one is fatty acid oxidation disorder. So fatty acids are the secondary energy sources for our body. So whenever there is a starvation, the ketones should be generated to maintain the glucose level. I mean, to maintain the energy levels. So as there is a defect in the fatty acid oxidation, so the ketones won't be generated, and they can have hypoglycemia. So hypoglycemia with ketones being absent, there is hypoketotic hypoglycemia, then we should be suspecting fatty acid oxidation disorder. So next is a pyruvate carboxylase or pyruvate dehydrogenase deficiency. These two enzymes are mainly involved in conversion of pyruvate to oxaloacetate. Pyruvate is the end product of glycolysis. So the pyruvate should be converted to oxaloacetate, and later it will be entering the Krebs cycle. So whenever there is a absence of a pyruvate carboxylase or pyruvate dehydrogenase enzyme, so there will be accumulation of pyruvate. So the excess pyruvate will enter the alternate pathway, and it will get converted to lactate. So whenever we are dealing with the primary lactic acidosis, so the first diagnosis should be pyruvate carboxylase or pyruvate dehydrogenase enzyme deficiency. So again, as the energy is not developed here, they can also present with hypoglycemia. So the finally is maple syrup urine disease, where it is mainly because of alpha-keto acid dehydrogenase enzyme deficiency. The ketogenic amino acids, that is isoleucine, valine, and leucine, they'll accumulated. As these are accumulated, they'll get converted into ketones. So apart in Gallup workup, only ketones will be present. So apart from that, all other glucose, ABG, lactate, ammonia will be normal. So then your first diagnosis will be MSUD. So there are IEMs which can present with normal Gallup workup. Those are pyridoxine-dependent seizures, biotin deficiency, and PNPO deficiency. Usually in this type of IEM, all the Gallup workup will be normal. Usually these disorders will be presenting with refractory seizures. So coming to evaluation of hyperammonemia. So whenever we have neonatal hyperammonemia, we should be answering two questions: whether the hyperammonemia was noticed within 24 hours of life or more than 24 hours of life. So if at all, if the hyperammonemia is present within 24 hours of life, we should be seeing the gestational age of the baby. So if it is a preterm baby, the first differential diagnosis will be transient hyperammonemia of newborn. If it is a full-term baby, still IEM can be a possibility, because your glutaric acidemia and pyruvate carboxylate deficiency or organic acidemia, they can be presenting with hyperammonemia within 24 hours of life. So what is this transient hyperammonemia of newborn? This is usually seen in preterm babies. This is mainly because shunting of the portal circulation into the systemic circulation, and thereby they bypass the liver. So as ammonia is not detoxified in the liver, they can present with hyperammonemia. Usually it is not genetically derived and it is not a recurring condition. And the next thing is, if hyperammonemia is presenting after 24 hours of life, then we should be answering whether there is, we should be saying whether there is acidosis or not. So hyperammonemia with acidosis, the diagnosis will be organic acidemias. So if there is no acidosis, if there is alkalosis, then we should be suspecting urea cycle disorders. To differentiate what type of urea cycle disorders, we should be doing plasma amino acid levels, that is citrulline levels and arginosuccinic acid. So if at all citrulline is markedly elevated with no arginosuccinic acid, then the diagnosis will be citrullinemia. So if at all citrulline is moderately elevated with the arginosuccinic acid present, then the diagnosis will be arginosuccinic aciduria. So if at all there is no citrulline, then we should be measuring the orotic acid levels, where if it is elevated, then the diagnosis will be ornithine transcarbamylase deficiency. If it is low, then your diagnosis will be CPS deficiency. Coming to evaluation of hypoglycemia. So whenever there is a refractory or persistent hypoglycemia, we'll be doing the critical sample, where it involves insulin, cortisol, growth hormone, and ketones. So we should be differentiating whether it is a hypoketotic hypoglycemia or ketotic hypoglycemia. So if at all, if it is a hypoketotic hypoglycemia, only two diagnoses are there. That is, it is hyperinsulinic hypoglycemia or mainly fatty acid oxidation disorder. So how to differentiate hyperinsulinic and fatty acid oxidation disorder? By seeing the free fatty acid level. So if at all, if there is hyperinsulinism, it will be inhibiting the fat metabolism. So there will be no free fatty acids in the hyperinsulinism. So in in fatty acid oxidation disorder, as they are not metabolized, the free fatty acid elevated and ketones will be low. And the other presentation is ketotic hypoglycemia. So where ketones are present, but there is hypoglycemia. Such disorders, they are growth hormone deficiency, cortisol deficiency, or even GST 0, type 0, type 3, 6, and 9. They can present with ketotic hypoglycemia. And some of the disorders, they can present with increased lactate along with ketotic hypoglycemia, or fructose 1,6 bisphosphatase deficiency, pyruvate carboxylate deficiency, or GST type 1. So coming to metabolic evaluation of metabolic acidosis. So whenever there is a metabolic acidosis, the first thing we'll be seeing the anion gap. If at all anion gap is normal, there are only two diagnoses, that is renal tubular acidosis or diarrhea. So if at all, if there is increased anion gap, then we should be seeing whether it is mainly because the lactate accumulation or is there any abnormal organic acids that are getting accumulated. So first thing, we'll be seeing whether the lactate levels are normal or elevated. If lactate levels are normal, then the increased anion gap is mainly because accumulation of abnormal organic acids. So the diagnosis will be organic acidemia. So if at all lactate levels are elevated, and again, the urine GCMS is showing abnormal organic acids, where the abnormal organic acid is dicarboxylic aciduria, then the diagnosis will be fatty acid oxidation defect. So if at all the abnormal acid is methyl malonic acid or propanic acid, again, it can be because of organic acidemia. So if at all the lactate levels are elevated, but there are no abnormal organic acids, then we should be seeing the lactate pyruvate ratio. So if at all lactate pyruvate ratio is elevated, then the defect lies in respiratory chain defects or pyruvate carboxylase deficiency. So if at all lactate pyruvate ratio is normal, then we should be seeing whether the baby is associated with hypoglycemia or not. So if it is associated with hypoglycemia, then the diagnosis will be GST type 1, fructose 1,6 bisphosphatase deficiency or carboxykinase deficiency. So if there are no hypoglycemia, then it can be because of pyruvate dehydrogenase deficiency. Coming to next diagnostic testing, there are two ways of evaluating a case of IEM. There is a provision of doing single test with multiple diagnosis, and the other type of test will be single test with single diagnosis. So single test with multiple diagnosis, mainly it is achieved by doing plasma amino acid assay or urine organic acid, or by doing tantamount spectroscopy, which will be involving amino acid profile and acyl carnitine profile. And single test, single diagnosis, mainly in disorders like biotinidase deficiency or galactosemia, we can send biotinidase enzyme assay. In galactosemia, we can do total galactose levels, galactose 1 phosphate levels, and GALT enzyme assay. So why we should do urine GCMS? Mainly it helps in differentiating organic acidemias and fatty acid oxidation defect. So the tandem-art spectroscopy, mainly it also helps in differentiating of FAODs and organic acidemias. But by seeing whether the odd chain is elevated or even chain is elevated, we can diagnose whether it is FAOD or organic acidemia. So if it is a odd chain elevation, then the diagnosis will be organic acidemia. So if it is a even chain elevation, then the diagnosis will be FAOD. This is the report of TMS where amino acid profile is present. If at all, if there is disorders like MSUD, the branched chain amino acids like leucine, isoleucine, and valine can be elevated. In phenylketonuria, the phenylalanine levels will be elevated. So the next is carnitine or acyl carnitine profile. As we can see here, there are C2, C3, C4, C5 levels here. So the crude method of identifying FAOD or organic acidemia, two things we should be remembering. So if at all, whether there is an even chain elevation or odd chain elevation. So odd chain elevation mainly directs towards organic acidemias, and even chain elevation mainly it points towards FAODs. So next is a plasma amino acid quantification assay by HPLC. Mainly it helps in diagnosis of urea sector disorders and amino acidopathies. And it also helps in, as we saw in maple syrup urine disease, by pre-PD metabolites or post-PD metabolites, whether the baby is responding to our treatment or not, that can also be ascertained by doing plasma amino acid assay. So some of the specialized testing that we use in specific disorders like non-ketotic hyperglycemia, which we will be doing CSF and plasma glycine ratio. If it is more than 0.08, then it is indicative of NKH. So in pyridoxine dependent seizures, we'll be doing levels of alpha amino adipic semi-aldehyde levels and pipeculic acid levels. So which is diagnostic of PDS. So even in serine synthetic defect, we'll be measuring serine levels in CSF. If low serine levels are there, then it is diagnostic of serine synthetic defect. So some of the other specialized tests, as I already discussed, very long chain fatty acids and plasmalogen levels are done in Zellweger syndrome. In diagnosis of congenital disorders of glycosylation, plasma transferrin isoelectric focusing will be used, where we can see type 1 and type 2 pattern depending upon the ionic charge. So in this picture, we'll know the different why we should do TMS along with urine GCMS along with plasma amino acid assay. We'll know the importance. This is as we can see here. This is propionic acidemia. In propionic acidemia and methylmalonic acidemia, in TMS it is mainly shown as C3 elevation. So we don't know if you do only the TMS screening, then we will not be differentiating whether it is methylmalonic acidemia or propionic acidemia. So in urine GCMS, it shows the excretion of hydroxypropanic acid. Then the diagnosis will be propionic acidemia. So if the excretion is methylmalonic acid in urine, then the diagnosis will be methylmalonic acidemia. So another example here is the HMG-CoA lyase deficiency and multiple carboxylase deficiency. Usually in TMS, they can have the C5OH elevation. To differentiate this, again, urine GCMS is very helpful. Depending upon the acid excreted, we can differentiate both these disorders. So coming to molecular diagnosis, mainly the molecular diagnosis will help us in genetic counseling and planning if the parents are planning for future pregnancy. So if at all, if your baby presents in a sick situation where you assume that baby can't make out, then we'll be collecting the blood for DNA storage. Later, it can be used for molecular diagnosis. So coming to MRI with MRS. So usually if we have no facility of doing a diagnostic evaluation of IEM, we can do MRI with MRS, and it can assist us in diagnosing such conditions. So in MRS, we'll be seeing lactate peak, galactitol peaks, and glycine peaks. So in mainly some of the IEMs which can present with MRI features are MSUD, where you can see cytotoxic edema of myelinated white matter, and propionic acidemia and methylmalonic acidemia, basal ganglia involvement can be present, and Zellweger syndrome, they can present with pachygyria or polymicrogyria. And respiratory chain defect, they can present with symmetric putaminal involvement, and isolated sulfate oxidative deficiency, they can present with diffuse white matter involvement, which can mimic features of HIV. So in this picture, we can see the basal ganglia edema in a baby with propionic acidemia, and this is the baby with Zellweger syndrome, where we can see the polymicrogyria and pachygyria. So coming to prenatal diagnosis of IEM. So mainly this helps in prevention of recurrence of the disease when the diagnosis is already confirmed in an index case. So what are the indications where prenatal diagnosis is indicated? So if the previous baby is affected, or the parents are carriers for autosomal recessive disease, and a woman is known to be a carrier or at high risk of being a carrier for X-linked recessive disease, or the antenatal USG which is done may show features of hydrops or visceromegaly, then we should be opting for prenatal diagnosis of IEM. So how to do? Mainly by doing chorionic villus sampling or amniocentesis. By the sample which is taken, we can do we can estimate the enzyme activity or genotypic mutations if the index is already been evaluated. Or else we can do substrate or metabolic profiling in amniotic fluid supernatant. So this is a table showing some of the IEMs which can present antenatally, like MPS type 7. They can it can present with increased NT, and Gaucher disease type 2, Niemann-Pick disease. They can present with hepatosplenomegaly, and lysosomal storage disorders. They can have features of placenta being bulky or pale, and Smith-Lemke optic disease. They can present with polydactyly, syndactyly, or thick lip. And NKH usually antenatally it will present with reduced or often fetal movement, And some of the IEMs which can present with fetal eye drops are MPS 7/4, mucorolipidosis type 1, type 2, GM1 gangliosidosis, Gaucher's disease, and Ullmann disease. So coming to management, so management mainly depends upon 4 strategies. As we all know, so whenever there is a defect here, so the substrate will get accumulated and it will get acted upon by enzyme P, and there will be formation of a toxic metabolite, or the product is not formed and later it can present with energy deficiency. So the main 4 principles of management of IEM are decreasing the substrate by using a special formula, or you increase the enzyme activity or cofactor by supplementing it, or enzyme replacement can be done, or stem cell transplantation can be done, or liver transplantation can be done. So if there is any energy deficiency, we will be supplementing it by special formula. So if there is any acute toxic metabolite accumulation, we should be removing the toxins by peritoneal dialysis, hemodialysis, or using a scavenging agents, importantly in hyperammonemia. So the management of IEM basis mainly in acute metabolic crisis, we should be taking care of airway, breathing. If at all, if there is any shock, hypothermia, hypoglycemia, dyselectremia, we should be managed. And if the features of sepsis are there, broad spectrum antibiotics like metronidazole or neomycin, mainly it also helps in reducing the production of organic acids by intestinal bacteria. And metabolic acidosis, it can be managed by IV sodium bicarbonate infusion. So coming to specific therapy, the first principle is substrate reduction. So whenever the baby presents with acute metabolic crisis, first we should be keeping the baby NPO as the main source of protein and lipid can be feeding. So after keeping NPO, we should be starting the baby on in glucose infusion to optimize the caloric intake. So if at all we are keeping the baby NPO, we should be for 24 to 48 hours. So if you are prolonging the NPO status, again it can cause endogenous protein breakdown. Again, toxic metabolites can accumulate. And once the baby is stabilized, we can start the baby on protein supplementation with 25% increment. And once a diagnosis is reached, we can start the special formulas without the offending amino acid. And usually the main management of dietary management will be the mainstay, because it can prevent the long-term complications. So this is the pristine company's meta-nutrition that we'll be using in our unit. This is for urea cycle defects. Like this, if at all if specific diagnosis like MSUD is made, we can get MSUD formulas. So at discharge, a quantified amount of breast milk along with the special formula can be given, and baby can be discharged. And some of the medications which can be used to reduce the substrate levels are metronidazole, antibiotic, mainly in organic acidemias, to prevent the formation of organic acids from bacteria. So these babies will be the organic acidemia babies. They'll be taking this metronidazole 7 days a month. And in case of long chain fatty acid oxidation disorders, we can supplement trieptanine, which is a synthetic medium chain triglyceride, which doesn't require the enzymes of fatty acid oxidation. So we can give medium chain synthetic triglycerides in long chain fatty acid oxidation defects. So in case of tyrosinemia type 1, nitisinone can be used, where it blocks 4-hydroxyphenyl pyruvate dioxinase enzyme, and it will prevent the formation of succinyl acetone, where it is toxic to brain and liver. So the second mode of treatment will be provision of deficient metabolites, and most commonly in most of the IEMs, it is the glucose is deficient. So we should be supplementing these babies with glucose infusion in acute metabolic crisis. And once they are stabilized, they can start with they can be started with special formulas. The third mode of treatment will be disposal of toxic metabolites. Usually, in case of hyperammonemia, they are depending upon the level of hyperammonemia, whether it is between 250 to 500 or 500. So if the level is between 250 to 500, then we can give the trial of ammonia scavenging agents such as sodium benzoate, sodium phenyl acetate, arginine hydrochloride. So mainly sodium benzoate acts by chelating with glycine, and where it forms purate, and later it gets excreted in urine. The sodium phenyl acetate mainly acts by chelating with glutamine, forming sodium phenyl glutamine acetate, and later it will get excreted in urine. Though arginine, why arginine should be supplemented? Mainly it acts as an essential amino acid in urea cycle disorder, and they can enhance the ammonia excretion. So once this loading dose has been given, so we should be seeing the levels of ammonia. So if ammonia levels are coming down within 4 hours of starting treatment, so we can continue this scavenging agents. So if at all within 4 hours of starting treatment, ammonia levels are not coming down, then it's an indication for doing peritoneal dialysis or hemodialysis. So if the levels are more than 500 or it is 250 and rising, then it's an indication to do peritoneal dialysis. So why exchange transfusion is not indicated here? Mainly it induces catabolism. Again, protein breakdown can be there. So we'll avoid doing exchange transfusion in such babies. And the fourth modality of treatment is increase in enzyme activity. In acute state of acute stage, we can use IV mode of treatment. In chronic stage, when the baby is when the baby can take orally, we can start oral supplementation. And the final mode of treatment can be liver transplantation or stem cell transplantation. So there are some IEMs which are vitamin responsive, like methylmalonic acid biotin deficiency, where biotin is supplemented, and multiple carboxylate deficiency, again biotin can be supplemented, and MACD, where riboflavin can be supplemented. Coming to dietary management of neonate at risk of IEM. So this is the protocol what we follow in our unit. So if at all there is any previous unexplained sibling death or suspected IEM, we'll be shifting the baby soon after birth, and we'll be starting the baby on IV dextrose infusion with graded express breast milk. And we'll be sending GALAC workup, urine GCMS, TNS within 24 to 48 hours of life. And once the GALAC workup has come, if it is normal, we can start the baby on direct breastfeeding, and once again we can repeat GALAC workup. So careful follow-up should be essential, as they can crash at any time. So if at all baby becomes unwell, we should be starting the emergency regimen. The future mode of therapy is gene therapy, where vectors are used, and the mutated gene can be excised and the normal gene can be put. So this is the area of scope of research in IEM. So take home message: IEMs are individually rare but collectively common, and there should be an high index of suspicion is essential for this diagnosis, and the algorithmic approach helps to kinch the diagnosis. And estimation of ammonia and baseline investigation in any sick neonate increases the detection and rate of these IEMs. So molecular diagnosis mainly helps us in genetic counseling and prenatal diagnosis of future pregnancy. So the main 4 principles of management are substrate reduction, providing deficient metabolite, and disposal of toxic metabolite, and increasing the residual enzyme activity. Thank you.
Thank you, Sachin, for a wonderful presentation. So the delegates or participants can post their question in the chat box. Meanwhile, I have few questions for you, which are commonly asked in exam. So can you name some condition where TMS is normal? Name some IEM where TMS is normal. You already mentioned LSD, lysosomal storage disease. That is because we are not looking for it.
Yes,
say for example, in US, if you take the newborn screening, they include LSDs also in the newborn screening. So so that is not what I want. I want like the profile which is
kind of been there, but it will not detect. Can you name some?
Mainly in urea cycle defects, where the proximal urea cycle disorders are not reported in TMS, ma'am. So we can miss the proximal urea cycle disorders in TMS.
Yes, agree. And I agree with Dr. Meenu. She said NKH. She's saying NKH. Can you say why, Sachin, why NKH will not be picked up? There will be glycine elevation. So why Dr. Meenu has put as newborn screening, NKH will be missed? Can you think? So if you are taking it as newborn screening, basically they look for only treatable disorders, right?
Yes,
So NKH by and large is not a treatable disorder. So they will not be reporting, even if they are finding a elevated glycine. If it is a newborn screening, they will not be reporting it. So if you are doing it as a diagnostic TMS, even though the test is the same, if you are sending it as a diagnostic TMS, they will be reporting, the lab will be reporting, because the purview of newborn screening itself is to identify treatable according to Wilson and Jugner criteria. It is to identify only treatable disorders. Yes, galactosemia and biotinidase, it is not by TMS, but you can detect in newborn screening both biotinidase and galactosemia, G6PD, etc. But the methodology is not TMS. It will be by different methodology. But they are kind of treatable disorders. So newborn screening purview will have galactosemia as one of the things. Okay, so you should not be thinking metabolic screening itself means just TMS alone. It will
yes,
be TMS along with the other biorad calorimetry. So
yes,
I'm just answering those who are put in the chat box.
okay.
Sachin, like you said the molybdenum cofactor deficiency mimics that of HIE. Can you elaborate on that? Like what aspect of molybdenum cofactor is a HIE mimicker? And also, can you name few other metabolic conditions which are HIE mimics?
Sulfite oxidase deficiency can also mimic as HIM.
Yes.
Usually, and molybdenum cofactor deficiency, the MRI features are mainly mimics HIM. That's what I remember, but I'm not sure.
Yes, yes. Actually, there are two aspects. One, they can present with delayed birth cry, not crying at birth, floppy at birth, not taking like proper breath. That is because of the presence of encephalopathy. They can present even like in the immediately after birth. Okay. Even for that matter, even pyridoxine dependent seizures or non-ketotic hyperglycemia. You also mentioned that these two can cause intrauterine seizures, right? So pyridoxine dependent seizures, PNPO deficiency, and NKH, all these presents as intrauterine seizures. So say for example, they are having continuously intrauterine seizures. Then when they are at birth, they can have like reduced blood flow to the brain because of intrauterine hypoxia because of repeated seizures.
Okay, ma'am.
So they are also HIE mimics.
Okay, ma'am. Okay, ma'am.
So if you okay, and of course a peculiarity of molybdenum cofactor is there will be cystic periventricular leukomalacia or cystic encephalomalacia, which is rapid onset. Say for example, you are taking a PVL. If it is going to take 4 weeks to happen, your cystic encephalomalacia will happen in 10 to 12 days time itself. So it will be very rapid. So that is also one of the important aspect you should remember. You said like just for the participants' sake, can you mentioned many times fructose 1,6 diphosphatase. There is a fructose in the name. So does it happen only when the baby is exposed to fructose? Can you explain that?
No, ma'am.
See that because fructose 1,6 diphosphatase happens in the glycolytic pathway itself. So they
ma'am.
need not be exposed to fructose.
Okay.
So they need not be exposed to sucrose or fructose or fruit juices. Unlike fructose intolerance, where only after exposure to fruit juices it happens.
Okay,
Whereas
ma'am.
fructose 1,6-diphosphatase, being a glycolytic pathway, they present with hypoglycemia and severe refractory metabolic acidosis. So the bicarbonate can be as low as in single digits, and it will be refractory. So they
Okay,
might
ma'am.
even need extracorporeal toxin removal for fructose 1,6-diphosphatase. So actually, there is one more question which has been okay. Baby with encephalopathy, what is the lowest ammonia cutoff you take to start on sodium benzoate? Dr. Subodh has asked.
Okay, ma'am. So usually
So,
ammonia levels, what we take cutoff for 75 and 150. If it is a preterm baby, if it is 150, and if it is a term baby, we take it as 75. But
okay.
when to start sodium benzoate? But if you are so minor elevation in ammonia doesn't cause cerebral edema per se. So if at all there are any Gallup features again showing in evidence of urea cycle defects where alkalosis is there, then we can think of urea cycle disorders and we can start on sodium benzoate or other sodium ammonia scavenging agents.
Okay, I'll just tweak your answer a little bit. Excellent answer. So basically, um, encephalopathy with ammonia level. Okay, so if there is encephalopathy itself, then it is an indication for ammonia scavenger. Okay, and you should be very careful about the unit what your lab is giving for ammonia, whether it is in microgram or micromole. Whatever Sachin is mentioning is in micromole. Okay, so if it is say like even if you are giving a leeway, any value above 100 micromole in a term baby or any value more than 150 micromole in a preterm baby, then there is an indication for ammonia scavenger. But you need to hold on. You have to think why this hyperammonemia, because hyperammonemia per se need not be urea cycle disorder. It can be even due to fatty acid oxidation defect or organic acidemia. So these two also can cause hyperammonemia. In that case, you need to just think a little bit more whether you have ruled out isovaleric acidemia. That is because if you have clinically sweaty feet order, actually pungent order, or like the socks removal order, like whenever you are removing the socks, similar order, which is an unpleasant order. Let us put us this way, unpleasant order. Then your one of your differential diagnosis for hyperammonemia would be isovaleric acidemia. In that case, you should not be using sodium benzoate at all, because glycine is the main chelator or toxin removal for isovaleric acid. So it gets removed as isovaleric glycine. So if you are going and giving sodium benzoate for them, it will chelate all the glycine and it will increase the encephalopathy. So you just have to remember, whomever is treating, you just have to remember whether at least clinically I am not having a suspicion of isovaleric acidemia. You need to come to a conclusion, then start on sodium benzoate. And also whenever you are starting on whenever you are starting your sodium benzoate for organic acidemia, you need to be more careful, because sodium benzoate also causes some liver dysfunction. So whether your LFT is normal, those things you need to just take care before starting sodium benzoate. Even though sodium benzoate is not an excellent drug, see, if you take abroad proximal urea cycle disorders, they start on carbiglu rather than sodium benzoate. But we do not have any option. We are still dependent on only sodium benzoate, which is like baking the quality of thing which is available in the supermarket. That only we are holding on. Even then Pristine is also producing now sodium benzoate sachets. So that you need to be careful. So that is regarding the answer for sodium benzoate. So I have a question here. Can you put some input on bifunctional protein deficiency? So generally, there are two things. trifunctional protein deficiency behaves like fatty acid oxidation defect. It behaves exactly similar to that of LCHAD. So they can have like a fasting hypoglycemia, hypoketotic state. They can have cardiomyopathy, myopathy. So that is trifunctional protein deficiency. Bifunctional protein deficiency is a lysosomal storage disorder. So it is one of the single enzyme lysosomal, it is a peroxisomal storage disorder. It is a single enzyme peroxisomal storage disorder. So in peroxisomal disorders, there are two varieties. One is peroxisomes itself is not formed. So the classical example is your Zellweger spectrum disorder, where peroxisome itself is not formed. That's why you call those disorders as peroxisomal biogenesis disorder. Other group of peroxisomal disorders are single enzyme deficiency, like how your MSUD is by single enzyme. Similarly, like in the peroxisome, one of the enzyme is absent. That is bifunctional protein deficiency. To my best of knowledge, it does not present in very early in newborn, but it presents during infancy. Hope I have answered the question. So back to Sachin. Sachin, can you say you put the thing as allo-isoleucine? What is
Yes.
the role of allo-isoleucine?
Mainly in monitoring MSUD patients, allo-isoleucine is the marker what we use for whether the baby has responded to a treatment or not. So that is the gold standard marker what we use for monitoring MSUD patients.
Okay. Other than that, basically, if you have your leucine isoleucine elevation in your TMS, to confirm whether it is MSUD or not, allo-isoleucine will be helpful. That particular thing. If allo-isoleucine is elevated, then it confirms MSUD. Because like sometimes other there are false positives for leucine elevation.
Okay, ma'am.
Yes, sir, it can present in the newborn period, but I have not seen, to my best of knowledge, bifunctional protein. I have seen one case presenting around 4 to 5 months of age. So the other question, Sachin, like you said basal ganglia involvement in organic acidemia. Can you name a common newborn condition where there is a closest differential diagnosis for basal ganglia involvement?
Chronic stress, ma'am.
Okay, so bilirubin, acute bilirubin encephalopathy or bilirubin induced neurological damage. So I will put the other way around. Maybe bilirubin induced neurological damage people will commonly think about. So you need to think about like organic acidemias also if there is a basal ganglia lesion, if because both can present with dystonia, etc. In your hypoglycemia approach, I would like to comment that some of the hypoglycemia where you have put as growth hormone deficiency and glycogen storage disorders will have late presentation. They will not have newborn presentation.
Okay, ma'am.
And your organic acidemia algorithm, dicarboxylic acid is not a consistent finding in FAOD. They happens only during fasting. Unlike organic acidemia, where you always get organic acid elevation in GCMS. Biotin deficiency. So I'm losing track. Okay, so you want to know about biotinidase deficiency, Dr. Alimelu? Is that I should be taking it as?
No. Yeah, Dr. Uma was just
Yes.
suggesting the basal ganglia involvement which you were
okay, madam. Okay, madam. Sure. Thank you. So I was not sure whether it is a question or an answer. Sorry about it.
Yeah, I didn't type the whole thing. Sorry.
Yeah, basal ganglia, like the lot of. Okay. Sure. Thank you for clarifying. So there is what madam was trying to say is there is a condition called as thiamine biotin responsive basal ganglia disorder. So you need to know that condition because they are like vitamin responsive. If you give thiamine and biotin to these responsive basal ganglia disease, so the basal ganglia thing get improved. So sorry, I just momentarily lost connection. Am I audible, Sachin?
Yes, ma'am. Yes, ma'am. You are audible.
Yeah. Thank you. So name a condition where, see, you said dextrose infusion is good. Yeah, good option because you want to reduce the catabolism and you want to start on dextrose. I want to just make a point that we should not be stopping protein for more than 24 to 48 hours. I have a question, Sachin. Name a condition where dextrose infusion is not optimal. So far, like we would have learned that like all IEM, you start on dextrose.
Yes, ma'am.
Can you think about
Like a pyruvate carboxylase or pyruvate deadenosine
yes,
deficiency?
excellent. So in mitochondriopathy, sometimes dextrose infusion is not good because it increases the lactate production. It enters into the glycolytic pathway and it causes more switch of the oxidative stress and causes strain on the respiratory enzymes as well. Last question, like are all IEM autosomal recessive?
No, ma'am. Some of them are X-linked recessive, like OTC deficiency, Arler syndrome, X-linked adrenoleukodystrophy. They can have X-linked inheritance.
Okay, good, excellent. So I think like my questions are over for Sachin. If there are any other questions, you can post in chat box. I'm not seeing anything. So thank you, Sachin, for the beautiful presentation.